Thank you very much, Christoph, for this kind introduction. So it's my pleasure, dear colleagues, to speak about catheter-based procedures to prevent stroke. So you have heard stroke is a very important issue, and I would like to bring you a little bit closer what we have in our interventional hands to prevent stroke. So 3 different topics: PFO closure, LAA, occlusion, and interventions in carotid artery disease. Just to stress a little bit again the importance of stroke, you see here statistics come from the US pointing to the very important issue that stroke is the leading cause of disability and stroke is the 3rd leading cause of death. And you see most of the strokes are ischemic strokes, and if you divide it into the most important causes related to this talk, so you see around 40% cryptogenic stroke associated with atrial fibrillation, but also in patients with carotid artery disease. In a European study, community-based in Spanish, they saw that there is an incidence of 133 up to 172 per 100,000 patient years, whether you're a man or a woman. And you see here the split between the different sources and causes of stroke. Case fatality rate was 12%, and severe disability of the survivors were 45%. So a high impact on clinical outcome, but also of costs, of course. And on the right-hand side, you see the potential targets is also for our procedure. So you see patent foramen ovale as a potential pathway for a thrombus originating from the venous system. You have an infarcted area, myocardial infarction might be the source of having a clot sitting in the apex, for instance, atrial fibrillation in combination with the LAA. Then we have, of course, aortic arch atherosclerosis, carotid artery disease, but also a disease in the arteries in the brain. If we go to Swiss data from the BAG, you might appreciate, if you look at the right upper side, black bar, women between 65 and 84 years. So you see that we have a high rate of fatal cases in perspective with a stroke, even more than if you have a myocardial infarction. So this is quite impressive to see that we have so much fatal cases after stroke, even more than in patients with a myocardial infarction. And the same thing is present if you look at hospitalization rate. So it's quite frequent in women, more frequently observed than after acute myocardial infarction here in red. So if we go back to our targets, I would like to start with the PFO. And the PFO is quite a controversial topic. And I would like to highlight first a little bit the anatomy. It's an incomplete closure of the septum primum and septum secundum. It's the most common cardiac abnormality, prevalence between 25 and 38% in the population, age dependent. The older you are, the less frequent the PFO is observed. But it's mainly responsible for a right-left shunt. In 95% of the cases, PFO is responsible for a right-left shunt. And associated, and this is a danger combination with the atrial septal aneurysm. This is present in 2.2% of the population. And if you have an atrial septal aneurysm, it's mainly and most frequently associated with a PFO. So you can see it is quite nicely. You can diagnose this in a TOE. You see right atrium, you see the bubbles, and here the bubbles passing through the PFO in the left atrium, and you see here the atrial septal aneurysm. But you can diagnose this as well angiographically. If you do an injection in the right atrium, you see how it passes the contrast to the PFO in the left atrial part. So there have been published some very nice cases showing that thrombus is really passing through the PFO to the left-hand side. So this is published in the European Heart Journal. So caught in the act, a riding thrombus in the PFO, here nicely seen in the CT scan, left atrium, right atrium, and this embolism actually caused a massive pulmonary embolism, but also cerebral ischemia, was treated surgically, and you can see here the thrombus actually brought out of the PFO in this emergency operation. Another interesting and quite impressive case is a 69-year-old female patient admitted with tachydyspnea, hypertension, and this oxygen saturation of 83%. And you see here in the EKG diagnosis of an inferior posterior myocardial infarction. She was brought to the cath lab. So you see here this akinetic zone here, and you might appreciate there is an occlusion of the distal circumflex artery. It was pre-dilated quickly, then aspirated, and you see a huge thrombus that was caught out and brought out of this distal circumflex artery. At the same time, because the patient had also the, of course, as we have seen, this large thrombus, the suspect of a pulmonary embolism, and you might appreciate in this angiography, immediately done after coronary revascularization, you see here there is thrombus shown by the arrows in the left pulmonary artery, which was treated medically, but at the same time, the pathway for this embolic myocardial infarction was looked for, and you see here a huge PFO associated with atrial septal aneurysm, and this pathway could be occluded immediately after the intervention by the implantation of a device. So as a discussion, although PFO usually is an innocent finding if you just look for a TOE, it may act as a detrimental pathway for paradoxical embolism, and besides of the occurrence of stroke, it might also cause myocardial infarction. So the first evidence comes out of this New England paper showing that if you have a PFO associated with an ASA, so you have a clearly higher risk of a recurrent stroke, but there was no association with a ASA alone or a PFO alone, but this combination was shown to be a high-risk setting. There is a meta-analysis showing the same thing, so if you look at cryptogenic stroke versus known stroke cause as control subjects, you see here a very high odds ratio of the risk of a recurrent stroke. Including several trials, there was a clear-cut positive correlation of this association. So the authors concluded that PFO and ASA are also associated with stroke, especially in younger patients, younger than 55 years old. So what treatment options do we have for secondary stroke prevention? So we have medical treatment, surgical closure, or interventional closure. And we know from different trials that aspirin might be as good as warfarin, but we know also, especially in patients with PFO and ASA, aspirin is insufficient and patients should be treated with warfarin instead. So regarding devices, device closures was introduced in 1992. What is really nice with this procedure is that you have a really high success rate. It's technically an easy procedure. You can perform it in less than 30 minutes, low complication rate, no TOE guidance is needed, and you can do it on an outpatient basis. Follow-up treatment consists of ASA and clopidogrel, and TOE is recommended 4 to 6 months to exclude rest shunt and thrombus on the device. And you see there are a lot of different devices on the market which has been shown to be feasible with regard to the implantation. So what about the evidence? This is a prospective registry including 308 patients treated with aspirin, warfarin, or closure with different devices. And you see that if you look at the long-term follow-up, patients performed or treated with a percutaneous PFO closure did in the long run, not significantly, but there was a clear trend to doing better with regard to recurrent stroke. And if you split it into the two parts of complete PFO closure or patients at baseline with more than one event, you see quite clearly that patients had benefit from a PFO closure interventionally. The same patient population follow-up 15 years, 103 risk pairs matched. So you see here regarding the composite endpoint, death, stroke, or TIA, it's clearly in favor of a closure of the PFO in this high-risk patient population. And also in this meta-analysis, combining the most important trials looking at recurrent neurological events, this was clearly in favor of a transcatheter closure of the PFO. But of course, these were no randomized trials, and therefore randomized trials were set up, and you are all familiar with this. The first was with the Starflex device, the closure trial, which remained negative, but there have been some issues with this trial. For instance, more than 40% of the PFOs had only very small baseline shunt. There were some thrombus issues, arrhythmia issues, but overall the conclusion was that there is no benefit. Another trial, the PC trial, also a prospective randomized one-to-one trial, medical treatment versus PFO closure with the Amplatzer device. And you see here the cumulative curve of the pre-specified endpoint, death, non-fatal stroke, TI, or peripheral embolism. We have a relative risk reduction of 37%, but this was statistically not significant. So it was actually also negative trial. If we look at the safety issues, and I think this is for the patient very important, we have seen that the implantation of the Amplatzer device was safe in this large setting, so we can perform the closure really safely. But what about the indication? We have another prospective trial. So we have the RESPECT trial, and the RESPECT trial is also a prospective trial, randomizing device versus medical treatment, also with the Amplatzer device. And you see there was a tendency in favor of the device group in the pre-specified endpoints. And interestingly, 3 out of 9 device group patients did not have a device at the time of the endpoint stroke. But it was an intention to treat analysis, and so therefore intention to treat cohort was actually the definitive endpoint. But if you look at as treated cohort, there was a benefit clearly in the group of the devices. If we combine these two major prospective trials, RESPECT and PC trial, so you see we are clearly on the left-hand side also favoring actually the implantation of a device in case of patients having a stroke, so as a prevention of a recurrent stroke. But of course, we need more data to clearly highlight the benefit of this intervention, and you see here a list of all the trials, and at the bottom you see the trials ongoing, recruiting patients with different devices, so we will have more data in this setting. More evidence comes also out of this study for evidence for being a little bit more permissive to do the intervention and to occlude the PFO. So this is a study highlighting that PFO as independent predictor in patients with pulmonary embolism, and the suggested mechanism was a paradoxical embolism. So I think the main indication for PFO closure interventionally is, of course, a secondary prevention for stroke, TIA, or embolic myocardial infarction. But one might also think to treat patients with sleep apnea to prevent from right-left and left-right shunt, or other indications might be possible in the future. So in summary, regarding PFO closure is safe and effective. Current observational data and meta-analysis support PFO closure, but more data are needed. So the second topic is the left atrial appendage closure, which is a dynamic structure. And you see there are different morphologies regarding the LAA. Imaging is done usually with a TOE, CT scan or MRI to really highlight the structure. And we know this might be a major source for thromboembolic events. We have different devices that follow the pacifier principle, so they try to really snug in the LAA and to occlude. We have different sizes available and usually implanted by a transseptal approach. If you use the embolizer, there is no need of oral anticoagulation afterwards. The Watchman, it's usually treated with oral anticoagulation. Just quickly, one nice example of a closed neck and the implantation of the device. After you see here the injection, and here a more technically demanding example in a wide neck here, and the lobe is not sits not nicely in the LAA, has to be replaced, but finally it is possible to implant this device just by angiographic guidance. So we know that the stroke risk increases with age. We know that warfarin is beneficial in the prevention of stroke, and we know but also that malcompliance is present. You see here in this analysis, after 5 years, only 30% of the patients are still on warfarin or oral anticoagulation. And even with the newer generation of anticoagulants, we have still the issue of bleeding. Also in this meta-analysis and different studies, you see that there is still an issue of bleeding events. So we have now interventional tools in our hand to occlude this potential source of emboli, shown in the PROTECT AF trial in a randomized fashion. And you see, if you look at the efficacy, it has been shown that the Watchman device is non-inferior to the Coumadin treatment, reduces stroke, and reduces especially hemorrhagic stroke. But there is a safety issue with these devices, and you can see here quite nicely there is a period of early hazard. Mostly pericardial effusion might occur, but over time, as published recently, it looks quite nice. And you see, if you have more experience with the device, you will have less complication by implanting the device. But also in our own patient population, you see that neurological events might occur, or most frequently embolizations or cardiac tamponade. So we have the indication to close this LAA in patients with a high stroke risk and problems with long-term anticoagulation. And of course, there are more data needed, and patients are recruited in different studies. So this is a summary regarding this topic. So we have actually LAA occlusion appears to be an important additional tool in the prevention of stroke, especially in patients at high risk of bleeds. But the current devices are still first-generation devices and can be just implanted safely in experienced hand, but we have unanswered questions. So rather quickly, carotid intervention, we know in asymptomatic patients we have, if the degree of the stenosis goes up to 90%, we have a higher risk of stroke. And quite quickly, the guidelines tell us that if you had a stroke and you have coronary artery stenosis, 50 to 70%, revascularization should be considered. And if you have a stenosis 70 to 99%, it is recommended to do a revascularization. If you are asymptomatic, there is actually only the proportion of carotid artery stenosis 60 to 99%, which may be revascularized. So this is an important thing to remember. Usually done carotid artery stenting with a wire passing through the stenosis, protection device is delivered, and afterwards a self-expanding stent is placed. But there are some inherent risks, of course, with this intervention. Anatomical high-risk criteria are pointed out here, and also high-risk comorbidities. So this is important for carotid artery stenting or carotid endarterectomy, needs to be considered and taken into account if you decide whether you go for stenting or surgery. So the last 3 slides. So you have here 3 30-day events rate in cath registry, and you see you have more events if you stent a patient which was symptomatic in comparison with asymptomatic patients, so you have better outcome in the asymptomatic setting. But if you compare surgical intervention versus carotid artery stenting, you see that the surgeons do usually a little bit better than the interventionalists. So we have in overall, in this summarized slide here, better outcome regarding stroke or death. So in summary, symptomatic patients should undergo revascularization, preferably surgical intervention. In experienced hands, carotid artery stenting can be equivalent in terms of benefit, but benefit in general of surgery as well is no longer present when complication rate exceeds 6%, and patient selection is important. Thank you for your attention.